So a little bit about the history of lung transplant, because I always find this fascinating that people don't realize that how long this has been going on. So in 1940, Dr. Dimikov was a heart and lung transplant, or a heart and lung surgeon in Russia, started to try to do lung transplants and heart transplants in dogs. That showed us that this could be done technically, that we use some of the same things that they did in 1940 today to make these surgeries possible. And then Dr. Miatis did the whole first lung transplants. That means he actually had a success when he did it, and he was able to keep the dog alive. And then the big deal was 1963. Dr. Hardy down at the University of Mississippi was able to perform the first successful human lung transplant. Now this kind of was the big turning point for lung transplantation. This showed that not only could we do it technically, but it also showed that we could do it and keep someone from passing away after the surgery. Unfortunately, Dr. Hardy's first lung transplant only survived 18 days. And retrospectively looking back at this, we know that's because of the selection criteria. Who he chose to give a lung transplant to was part of the problem. He chose a patient that had a bad lung disease, but had it because of cancer. And we know that if we give somebody who has cancer immunosuppressants, that can actually make the cancer worse. And that's one of the things that when we deal with lung transplant, it's always a risk, but we have to kind of weigh that risk with the reward. So one of the things that we learned from that is that even though we did this lung transplant and was successful, it's probably not the best idea to do in certain patients. That's where patient selection becomes such a key issue. But then in 1986, so we went from 1963, when Dr. Hardy did the first one, and everyone said, whoa, we got to stop doing these, to 1986, when the Stanford group and the Toronto group started doing and reporting successful lung transplantations. The first patient that was done at Toronto actually celebrated his 30th year post-transplant. Now, he didn't survive all those years, but 30 years since their transplant. And they had a huge thing. They brought the original surgeons back, the original team back. If you ever have a chance, go to YouTube and Google it and talk about the first lung transplant. It's a very, very interesting documentary. So all these things that they did in 1963 to 1986 kind of led to where we are clinically today. And that's with the advancements in the drugs and the techniques to make lung transplant surgery viable. So what should people expect from a lung transplant? Lung transplant is meant to improve your quality of life, okay? A little bit more or more? More? Okay. So lung transplant is to improve quality of life. It's also to provide better exercise endurance, okay? Remember exercise endurance, that's going to be a key. It's also to provide less hospitalization, improved short-term survivability, okay? And then improved longevity. Now, the key thing is improved quality of life, improved exercise tolerance. And we're going to talk about that a little bit more. So, who is a transplant candidate? Technically, everybody's a lung transplant candidate until we start looking at what's going on with them and why they may not be, okay? Patients with C.O.P.D, emphysema and bronchitis, pulmonary artery hypertension, interstitial lung diseases like BOOT, I knew what it was, SARCOID, LAM, dermatomyomyositosis, had that one too, all these little tricky ones you guys are throwing out there. But all of these patients are candidates for lung transplant. Now, some patients that are not transplant candidates. Patients with lung cancer, that's one, okay? The second one is patients with severe pneumoconiosis, which you might know as black lung disease. Black lung disease has a grading scale, and depending on how far gone the tissue is, that is kind of gets you in and out of lung transplant. But up in those two disease processes, cancer and black lung, are really the only ones that lung transplant centers won't look at, okay? Now, I'm not saying that doesn't come across our desk all the time. Certainly it does, but we have to kind of call the person and say, you're just not a candidate. And that's one of those calls that our pre-transplant coordinator, Heidi, probably makes on a weekly basis. The other candidate things that we look at are all other medical and surgical therapeutic options are done, okay? So that means if you've had COPD and you were a candidate for lung volume reduction surgery, you had had the opportunity to look into that. Now, my surgeons are just like any other surgeon here in the country. They're going to look at people and say, hey, is this a good candidate for lung volume reduction surgery? And if you're not, then they're going to kick you back over to transplant. There are lots of reasons why people are not good candidates for lung volume reduction surgery. Then they may be a good candidate for transplant, but we want to exhaust that surgical option first. And then drugs. So we know that from our experience, a number of patients come back or get referred to us, and they come back to us multiple times, and we're like, you're not completely medically managed. So you're not on all of the right drugs at this point. Let's get you on those right drugs and let's see how you do. A number of patients we do that for, we talk to their referring doctor or the referring physician and say, hey, this is what we've done. Let's give them 3 months. If they're not any better or they're not improved, we'll see them back. Sometimes that's all it takes. We just mix some things up and they feel better. They don't need a transplant because they feel comfortable with what we've done. Other things, predicted less than 2 years survival. So we know that transplant is not meant to have someone survive 25 years, okay? So if we're looking at a transplant, we're looking at someone that's got less than probably 2 years to survive with their native lung disease. Now, one of the problems with that is that can be tricky in diseases like C.O.P.D, and I'm going to talk a little bit more about that, but it's hard to kind of predict how long someone has C.O.P.D, because people get diagnosed with C.O.P.D, and then they stop smoking, and they can live for many, many years without ever going on oxygen. But then you have some people who were diagnosed very, very late, and they're on oxygen, and they have really poor quality of life, and they may be a good person for a lung transplant. So we just have to kind of outweigh who and what the kind of situation is. It always depends, on the person. It's not what we want. It's not what other people want. Everybody has to find what's important for them and what's a good match for them, just like choosing a lung transplant center. UVA may be one place for some people. INOVA may be another place. Duke may be a third place. It's really up to the person that's actually getting the lung transplant and making that decision, what's a good fit and what's a good reason for it. Transplant candidates should, and it says it here, it says poor quality of life. Poor quality of life is dependent on the person. I mean, we have a lot of patients that come to us that work full time and come to our clinic visits and they're like, I gotta go to work. We also have a lot of patients that come to us and they can't do anything because their quality of life is so poor. But it doesn't necessarily mean that you're not doing anything and you're disabled. It means that your quality of life you feel would be improved with a lung transplant. And then our team kind of evaluates that as well. So one of the other things is you're declining on adequate therapy, which I already said. No concurrent medical issues or systemic disease. So if you come to us or if you get referred for a lung transplant and you have end-stage liver disease as well, or end-stage kidney disease, or end-stage heart disease, congestive heart failure, we have to kind of look at that. Is that a good thing to be trying to do on someone with another end-stage disease? It's not necessarily the worst thing that we can do, because we do multiple organ transplants at one time, lungs and liver, lungs and kidneys, hearts and lungs, but we have to make sure it's the right person at the right time with the right organs. You need strong psychosocial support. And anybody who comes to us, that's going to be beat into them. That you got to have somebody who's a rock for you. That when everything else falls apart, they're going to be there. Because if you don't have that and you get in trouble, who's going to be there to support you? I mean, we're certainly going to be there. But at the same time, you're going to need a person to drive you to the clinic appointments. You're going to need a person to help you go get meds. You're going to need a person that's going to get things that you need to get done. So you really need that. Physical rehabilitation potential. That's just a fancy word for exercise, okay? You got to be able to exercise. And you got to be able to exercise before transplant. That way, when we do the surgery on you, we can get you rehabbed afterwards, okay? And pulmonary rehab is the key. And then adequate insurance coverage. Now, this is changing the dynamic with all the healthcare insurance things that are going on right now. We have a full-time financial coordinator that's all she does is look at your finances and say, will they be able to afford their meds? Will they be able to kind of get through the surgery and be okay and still be able to make their house payments or their car payments or whatever other bills you might have? That's what she does. She sets you up and kind of looks at you and actually comes and talks to you as part of our evaluation process. Because we know that if we do this surgery on you and then a year later you have to declare bankruptcy, that's going to affect you, okay? And we understand that, and we've learned that from past experiences. So we want to make sure that we get you in the best possible financial shape that we can prior to surgery. So our team at UVA, we have 3 full-time cardiothoracic surgeons that they do lung transplants. We have a total of 15 cardiothoracic surgeons that are available to do lung transplants, but our 3 full-timers are the ones that do the 90% of the transplants. 2 transplant pulmonologists, that's their only job, is transplant. Okay? They see patients in clinic, they round on them in the hospital, they do other things that have to do with transplant. So that's their job. 4 lung transplant coordinators. We have a pre-transplant coordinator. Her name's Heidi. She's going to be the first one that's probably going to contact you. She's going to be the one that's going to ask you all kinds of embarrassing questions, put them down on a piece of paper, and then feed them to our transplant pulmonologist. 1 inpatient NP. That actually used to be my job. I did that for 7 years. Every day in the hospital, seeing patients with the physicians, making sure everything's getting done that needs to happen for our lung transplant patients. And then 2 post-transplant NPs. So that's myself and Beverly. Okay? Beverly and I are the 2 go-to people after transplant. If you need something, your first call should be to us. Now, if you need a bologna sandwich, don't call me. But if you need something that has to do with lung transplant, please give us a call and let us know. We have a full-time social worker, Mr. Bill Potts. Mr. Bill Potts is the lead transplant social worker at UVA. Okay? The guy's really smart. He's a little intimidating. He's very tall. He's a marathon runner. Okay? But at the same time, he knows the resources that are out there to help end-stage lung disease patients get through what they need to get through. And he is a wealth of knowledge. I can't say enough about that guy. He has taught me so much in the last 10 years. Financial coordinator Stacy, who I said, 1 transplant pharmacist. We actually have multiple transplant pharmacists that our patients see in the clinic, but we have 1 full-time guy that's basically our go-to person. And it's great to have him because there are medication questions, even though I prescribe them, I don't know the answer to it. I'm like, well, let me call Winston. Maybe he knows. And then 1 transplant dietitian. She's about this tall. She's about 90 pounds. She runs around like she's been drinking Red Bulls constantly. And it's like, slow down. So, but she's great because she can help you, a number of ways after transplant. So I want you to look at this picture. This is Tina, and some people here know who she is. She's a patient that had cystic fibrosis. And I'm going to talk a little bit about her, but I want you to remember this picture. So why are we doing transplants? And this data is a little bit old, but it's the best we have currently because things changed in about 2013 and we don't have all the numbers yet. So 34% of the lung transplants performed in the United States were for COPD. 6% were for alpha-1, which is a form of COPD that is a genetic component to it. 24% are for interstitial lung diseases like BOO and IPF and a couple of other ones. 17% for CF. And then 20% were for the others. That's where you get your LAMs, your dermatomyositis, your SARCOID, your other things like that. So, from 1995 to 2012, roughly 38,000 lung transplants performed in the United States. That's a drop in the bucket. If I think back to the last numbers I heard about lung disease, we're talking hundreds of thousands of people have lung disease. Of that hundreds of thousands, probably 40% are end stage that might benefit from a lung transplant. We don't have enough organs to kind of make all that happen. So that's kind of the crux of our job. We're limited by a supply and demand issue.